Okay, so we're going to start with our seminar today. You are going to see the short biography of Professor Rafael Vieira on the Moodle. So I'm not using more time on this. He is going to present you something that results from his own PhD work. Okay. Thank you very much to accept the invitation to speak to the students, and please go on.
Thank you, Ruth and Lenny, for inviting me. So my name is Rafael Vieira. I finished almost a month ago the PhD in Clinical and Health Services Research, and I was invited to come here and to show you to the Health Data Science program that we at the Clinical and Health Services Research also can do some interesting things. Of course, not as interesting as you guys can do here. So my thesis was entitled Using Real-World and Secondary Data to Estimate the Global Burden of Allergic Rhinitis, and it was supervised by Professor Bernardo Sousa Pinto, as well as co-supervised by Professors João Fonseca and Luisa Smith. Please feel free to interrupt should you have any questions. So allergic rhinitis disease that I studied in my PhD is a multifactorial chronic disorder that is highly prevalent across all ages. Estimates of its prevalence range from 20 to 40% globally, depending on the region. And patients with allergic rhinitis present with multiple symptoms. So nasal symptoms are always present, but then many patients also present with ocular symptoms, and around 40% of patients with allergic rhinitis also present with asthma. This is important because patients with allergic rhinitis and asthma are known to have a more severe phenotypes or a more severe disease. And indeed, the Ariamidol hypothesis suggests that allergic rhinitis alone and allergic rhinitis and asthma should be regarded as two different entities. Now, the symptoms that the patients with allergic rhinitis present, they are highly variable, both within the same individual and between individuals, and that is because symptoms depend on disease control. And disease control itself is affected by multiple factors such as medication use and allergen exposure, for example. And they can have an important impact on patients' lives, both on work and academic productivity and on quality of life. Now, the issue is that because fortunately, as you probably know, patients with allergic rhinitis rarely go to the doctor and spend most of their time at home, the picture we have of the impact of allergic rhinitis can be quite incomplete and not representative of the true impact of allergic rhinitis. And that is because we only see the impact that disease has when patients go to their doctor. So this makes it particularly difficult to study the impact of allergic rhinitis, especially if we rely on classical sources of data. Now, as I'm sure you know, classically data is categorized into primary or secondary data. However, over the past decade, there has been a growing interest in a new category of data, the so-called real-world data. Now, what real-world data actually are remains controversial. So some authors define real-world data as any data outside of randomized controlled trials, while others will define real-world data as any data coming from observational studies, whether that's from a primary or a secondary data source. And others yet use the term real-world data as a synonym of secondary data. Now, this is the case of the Food and Drug Administration. So the FDA defines real-world data as data related to patient health status and or the delivery of healthcare routinely collected from a variety of sources, including electronic health records, medical claims data, data from product or disease registries, and data gathered from other sources, such as digital health technologies that can inform on health status. Rather than debating on the definition of real-world data, we realize that these digital health technologies can be particularly important to provide insights into the burden of allergic rhinitis. And that is because mobile health allows us to obtain direct patient data, which allows us to get insights into a patient's health status between healthcare visits, thereby allowing us to have a more representative view of the impact of allergic rhinitis on patients, quality of life and work and academic mobility. Now, there are many mobile health apps available for the self-management of allergic rhinitis, but out of all mobile apps available, MaskAir is the one that is the most extensively validated, both clinically and methodologically, and therefore, actually, my PhD thesis used mostly data from this MaskAir mobile app. So MaskAir is a mobile app freely available on Google Play and Apple App Store in 30 countries, these here in red, and it comprises a daily monitoring questionnaire where patients can report on the impact of allergies and their allergy symptoms by means of visual analog scales, as well as on their daily medication use. And it also includes optional questionnaires, which allow for the assessment of the impact of allergic rhinitis on work and academic productivity, namely a validated questionnaire named the Work Productivity and Activity Impairment Questionnaire, as well as questionnaires that assess quality of life, namely the EQ5D questionnaire. So considering the potential of for MaskAir to assess the impact of allergic rhinitis, basically the main aim of this thesis was to study the impact of allergic rhinitis in terms of academic productivity, work productivity, and quality of life. And for each of these three domains, we assessed both the actual impact or burden and also the factors that modify this impact. So as you will see throughout this, my thesis, I used several methodological approaches from mixed effects models to Bayesian modeling, post-stratification, for example. But I will now go through each study in more detail and try not to take too much time. So for the first study, we assessed the impact of allergic rhinitis on academic productivity. We took MaskAir users aged 16 to 29 years old and performed two separate analyses. So we took responses to the WPAI questionnaire. That's the questionnaire that's validated. Interesting, because I am not moving. Okay, so my mouse on the screen there is not in the same.
Yeah.
So I was pointing at the wrong things, apparently, at least from your point of view. Well, we looked at the WPAI questionnaire, which is the validated questionnaire that allows for the assessment of the impact on academic productivity. And we compared responses to the WPAI questionnaire in well-controlled weeks versus poorly controlled weeks. And in the second analysis, we looked at the WPAI questionnaire, but comparing patients with allergic rhinitis alone and patients with allergic rhinitis and asthma. We used Bayesian modeling to model the responses to the WPAI questionnaire in terms of absenteeism, that is days of school missed, presenteeism, that is reduced productivity while at school, and total academic impairment corresponding to the sum of absenteeism and presenteeism. So in terms of results, and for the first analysis, this was a rather small sample. We have 91 responses from 70 users, of which around 40% were well-controlled weeks. And in terms of academic impairment, we found a median academic impairment of 8.9% in well-controlled weeks versus 37.2% in poorly controlled weeks. That is, patients in well-controlled weeks reported losing a median 8.9% of their academic hours versus 37.2% in poorly controlled weeks. We found presenteeism, that rather than absenteeism, to be the main driver of this academic impairment. Then, when comparing patients with allergic rhinitis alone and allergic rhinitis and asthma, we included 662 responses from over 300 users. Around 40% had both allergic rhinitis and asthma. And in terms of total academic impairment, wait, because this will not show anyways at home, never mind. In terms of total academic impairment, we found actually similar academic impairment of around 30%, both for allergic rhinitis alone and allergic rhinitis and asthma, and we found presenteeism to be the main driver of the reduced academic productivity. We then went on to study the factors that modify the impact of allergic rhinitis on academic productivity. So once again, we included mass care users aged 16 to 29 years old, and we built, in this case, mixed effects regression models adjusted for user, country, and month of the year as random effects, and then for many other variables as fixed effects. We focused on three key independent variables, which were the visual analog scales for nasal symptoms, for ocular symptoms, and for asthma symptoms. And our dependent variable was the visual analog scale for the impact of allergies on academic productivity, or VAS education for short. So in terms of results, here we managed to include over 13,000 responses from nearly 2,000 users. Mean age was around 20 years. We found strong correlations between all symptom visual analog scales and the visual analog scale for the impact of allergies on academic productivity. But looking at the regression coefficients in more detail, we found nasal symptoms to be the ones that had the highest impact on academic productivity, with a regression coefficient of 0.38. So this means that for every 1 point increase in nasal symptoms, we expect a mean 0.38 increase in the VAS education. Ocular symptoms and asthma symptoms, we found smaller regression coefficients of 0.18 and 0.19. And then after studying academic productivity, we went on to study work productivity and corresponding indirect costs. So once again, we included mass care users with allergic rhinitis. We classified weeks into well-controlled weeks, partially controlled weeks, and poorly controlled weeks. And we looked at responses to the WPAI questionnaire, but this time to assess work productivity. This questionnaire assesses both work and academic productivity. We used Bayesian modeling to compute the number of hours of work lost per week. And then what we did in order to estimate indirect costs, so costs associated with reduced work productivity or absenteeism due to allergic rhinitis, we took information on mean and median wages from 40 countries from the OECD database, and we computed wage distributions based on mean and median wages for each country, and then we combined these distributions with the distributions for the number of hours of work lost per week to compute the weekly amount of, in this case, US dollars adjusted for purchasing power parities lost per week for each country. We used US dollars adjusted for purchasing power parities as our currency. Well, we had to pick one currency and we just picked US dollars, but then we adjusted for purchasing power parities to account for differences in the purchasing power parities in different countries, because we had 40 countries which were very heterogeneous. So here we included 397 responses from 228 users, mostly coming from well-controlled or partially controlled weeks. And in terms of total academic work impairment, we found a median work impairment of around 3% in well-controlled weeks, 26% in partially controlled weeks, and 40% in poorly controlled weeks. Once again, presenteeism was the main driver of this reduced work impairment. This is for allergic rhinitis alone. Then when looking at allergic rhinitis and asthma, we have less responses, but in terms of work impairment, we found a median work impairment of 8.6% in well-controlled weeks, 31% in partially controlled weeks, and almost 70% in poorly controlled weeks, with presenteeism being the main driver of the work impairment here as well. Then when looking at costs, I will not bother you with costs for all countries, but for example, looking at the case of Portugal and allergic rhinitis alone. So these are the weekly indirect costs for all countries, but for Portugal, we estimate a median loss of 140 US dollars adjusted for purchasing power parities for patients with allergic rhinitis alone when they have a poorly controlled week. For patients with allergic rhinitis and asthma in a poorly controlled week, we estimate a loss of $280, so double the amount of the loss with allergic rhinitis alone. So we then went on to assess the factors, in particular the symptoms which are more associated with this impact. Once again, this was very similar to what we had done for academic productivity. We focused on the same 3 sets of symptoms, so nasal symptoms, ocular symptoms, and asthma symptoms. And our dependent variable this time was the visual analog scale for the impact of allergies on work. In terms of results, we have 260,000 responses from over 20,000 users. You can see here once again that actually very consistent with what we had found for academic productivity, nasal symptoms were the ones that had the highest impact on work productivity with a regression coefficient of 0.38. Once again, ocular and asthma symptoms, they have lower regression coefficients of 0.22 and 0.24 respectively. We then did also an additional analysis. So we compared the median visual analog scale for the impact of allergies on work between patients with no evidence of asthma, possible asthma, and probable asthma. And we found relevant differences for the median VAS work between patients with possible or probable asthma versus patients with no evidence of asthma, with an effect size of 0.6, which represents a median, moderate effect size for this difference. And finally, we assess the impact of allergic rhinitis on health-related quality of life. So, as I told you at the beginning, MASC-AIR includes the EQ5D5L questionnaire. That's a multi-attribute questionnaire that allows for the assessment of health-related quality of life. It allows for the assessment of health-related quality of life because it assesses 5 domains, and it also includes a visual analog scale to assess overall quality of life. However, responses to the EQ5D5 and there are concerns that mHealth data may not be fully representative of the population and may be subject to selection biases. So what we did was we first used the responses to the EQ5D5L questionnaire and built multivariable mixed effects models. Multivariable mixed effects models per sex, age group, and country. And then we added context level information, which in this case were the utilities in the general population of each country. So we took information from the literature on what were the utilities or quality of life in each country in the general population, and we added that to the model to account for some potential biases related to the country. And then we added information on the distribution or on the number of people with allergic rhinitis or asthma for each country, age group, and sex to allow for the post-stratification to also solve some potential selection biases in terms of age and sex representativeness. So we did this and we computed mean utilities and mean visual analog scale for DQ5D for well-controlled days, partially controlled days, and poorly controlled days. And then we used Monte Carlo simulations to account for uncertainty to compute standard errors. So for allergic rhinitis alone, we included 1,454 users, over 4,000 responses. And in terms of utilities, you can see here on the right, that utilities varied both between countries and within a country between levels of disease control. We found similar utilities. So, for example, in general, we found similar utilities for good and partial disease control. However, the big drop in quality of life was clearly for patients who had poorly controlled allergic rhinitis, in which utilities were around, I would say, 0.8, except for Belgium and Netherlands with 0.73 and 0.75 respectively. So Belgium here and Netherlands here were the ones that showed the lowest quality of life or lowest utilities representing quality of life in poorly controlled allergic rhinitis. Then for allergic rhinitis and asthma, we, once again, utilities varied both across countries and between levels of disease control. we found once again similar results in terms of utilities around 0. I'm pointing at the wrong thing, around 0.8 here. However, for well-controlled and partially controlled allergic rhinitis, we actually found lower utilities than what we had for patients with allergic rhinitis alone. And then we found similar results when looking at the Q5D visual analog scale, both looking at allergic rhinitis alone and allergic rhinitis and asthma. And finally, you see, my thesis was basically always the same structure. So we assessed the factors that modify the impact of allergic rhinitis on health-related quality of life. So once again, we focused on the same 3 sets of symptoms. However, this time, because we wanted to more precisely isolate the effect of each specific symptom, what we did was we performed some stratified analysis. Sorry, I meant to point at this. Some stratified analysis in which we restricted our analysis to observations in which only one set of symptoms was not well controlled. So, for example, to assess the impact of nasal symptoms on quality of life, we restricted our models to those observations in which both ocular and asthma symptoms were well controlled, and only nasal symptoms were allowed to be not well controlled. And we did this for nasal, for ocular, and for asthma symptoms separately. So we built different models for each of these sets of symptoms. So we performed the analysis in terms of utilities and in terms of EQ5D visual analog scale, but in general, what you can see is that for ocular and nasal symptoms, we found similar results in patients with allergic rhinitis alone and for allergic rhinitis and asthma. However, we found asthma symptoms in general to have a higher impact on quality of life than ocular or nasal symptoms in patients with allergic rhinitis and asthma. So, in terms of, to summarize, actually, we found that uncontrolled allergic rhinitis substantially impairs academic and work productivity, primarily through presenteeism, that is, reduced work or academic productivity while at work or at school. And we found that nasal symptoms are the main driver of this reduced productivity. We also found a similar impact of allergic rhinitis alone and allergic rhinitis and asthma on academic productivity. However, on work productivity, we found a greater impact of allergic rhinitis and asthma. And then we also found an important impact on health-related quality of life, which was more substantial for patients with allergic rhinitis and asthma. And finally, we found asthma symptoms to be the main driver of reduced quality of life in patients with allergic rhinitis and asthma. Now, there are some limitations to this work, which fortunately were not that important enough for the jury to fail me, so yay, but still there are some limitations. So there's a potential for selection biases in mobile health studies, namely due to an overrepresentation of younger patients or patients more concerned about their health or even more severe patients. What we did to account for this was to perform our analysis always, as you may have noticed, according to disease control. So we never present our results overall. We always stratify according to disease control, specifically because we know that patients are more likely to report their symptoms when they feel bad. And also we perform post-stratification when it was possible to account for some selection biases, namely in the quality of life study. Another issue is that we rely on self-reported data, including for diagnosis of allergic rhinitis and for the diagnosis of asthma, and we do not collect information on academic performance or income. This would actually hardly be feasible in a study like this. And we also do not collect information on other potential comorbidities, particularly non-allergic comorbidities, which may also impact productivity and quality of life. There are, however, also some strengths. First, this was an innovative use of mobile health, allowing for the use of a consistent methodology to study the impact of a chronic disorder, in this case, allergic rhinitis. We relied mostly on validated patient-reported outcome measures, namely the visual analog scales. They were all validated. EQ5D5L is more than validated as a questionnaire to assess health-related quality of life, and also WPAI, which is validated for assessing academic and work productivity. And we use the allergy-specific version, which is specific to assess the impact of allergies. We also used some, I would say, robust methodology, namely mixed effects model, Bayesian methods, and post-stratification, and this allowed us to contribute to a more comprehensive understanding of the impact of allergic rhinitis, both on productivity and on quality of life. So, in conclusion, if not properly controlled, allergic rhinitis poses a substantial burden, and this burden is even higher for patients with allergic rhinitis and asthma. This makes it all the more important to systematically assess patients with allergic rhinitis for the presence of asthma, and in addition, while individual patients' values and preferences should be considered when caring for patients with allergic rhinitis, we did find nasal symptoms to consistently be one of the main drivers of the impact of allergic rhinitis. So this also calls for the need of properly controlling nasal symptoms in these patients. These findings, I think, is interesting because these findings have been used to inform on the update of the allergic rhinitis and its impact on asthma guidelines, the 2024, now more likely 2025 update because it's not been released yet. Namely in terms of the resources required for allergic rhinitis and on the values and preferences of patients with allergic rhinitis. And as is the philosophy of the allergic rhinitis and its impact on asthma group, these findings called for the need of a patient-centered and integrated care approach to manage these conditions effectively, focusing not only on symptom control, but also on meeting the broader needs and priorities of these patients.